I think I hope you everyone enjoyed in case. We discuss regarding the osteotomy because it's osteotomy is one of really it's very difficult topic because while we are performing then we cannot see the case this osteotomy.
ভালো টপিক্স median osteotomy, paramedian osteotomy, lateral osteotomy.
So osteotomy is really one of the most difficult topic. How can we simplify the osteotomy?
Controlled fracture.
In first, you know what exact the osteotomy. What is osteotomy? Because we have the different method in these days just to modify the bony pyramid like osteoctomy, like rhino sculpture by the Piaggio, by the cylindrical burr, powered instrument, scissors. But traditionally, the osteotomy we use most frequently for modify the bony pyramid. What is osteotomy? Osteotomy is basically the control fracture of this ascending process of the maxilla just to correct the bony vault. In osteotomy, not we fracture the nasal bone, we fracture the ascending process of maxilla, and it's really an essential component of rhinoplasty, but really it is one of the difficult and there are a lot of challenges in osteotomy. Challenging factor that number one, because when we performing the osteotomy, we couldn't see the process. We just only the feel by your fingers. And another important thing, the bone thickness. If you compare in a one patient on the same side, the bone thickness is not same. On the one side, from proximal to the distal and the mid part, the bone thickness is the different. So these factors make the complicated the osteotomy. So finally, the goal of osteotomy, we reposition the bony vault while maintain their stability, and we get obtaining the desirable width and maintain the dorsal aesthetic line. These are the goal of osteotomies. Now, whenever we indication, then certain we have the contraindication of osteotomy also. Sometimes when you have like in a binder patient or whenever a small nasal bone, when your patient have a small nasal bone, then osteotomy is contraindicated. Why? Because when you have a very short nasal bone, then obviously you have comparative the long upper lateral cartilage. So when a patient have a very short nasal bone, then during the osteotomy, there is a lot of chance of the fragmentation of the nasal bone. So sometimes what happened, the upper lateral cartilage lost the support and there is an inferior medially collapse, and eventually the patient develop the inverted V deformity. So like in the binder syndrome cases and very short nose cases, the osteotomy whenever you attempt, then you do very judiciously. And another contraindication, then when you wear a high like the heavy glasses, or when a patient have a scar tendency. So when you examine like in your OPD, the patient have some scar mark, then particularly you ask to the patient, because sometimes if you need the external osteotomy and maybe the patient have the scar tendency. So these are the contraindication of the osteotomy. Now, before to osteotomy, because mostly my beginners and a lot of friends, then they told me osteotomy is very difficult. But can you realize that you have all these knowledge before to the osteotomy? So there are certain points before to osteotomy, you know, need first either your patient is need or not osteotomy. How you judge? Because I think practically there are so many times we ask to your assistant, ask to the sister, can you think this patient need the osteotomy? Can we do or not? Because we are biased regarding. So first you know when you need the osteotomy. So how you decide if your bony base width of the dorsum is more than 2/3 of the intercanthal distance or ala base width, then you go for the osteotomy. Now, suppose if you need the osteotomy, then you need all these. First, the morphology of the bony nasal vault. That means the length, the width, the thickness of the bone. You need all these things. And then you need about the knowledge of the osteotomes and surface landmarks. And then type and the indication, and then different type of the osteotomy, you have the different type of the pattern and the sequence also. So these all things you just first you examine the patient and decide. First, if we discuss the component of this bony nasal vault, then this bony pyramid consists by the 6 important attachment. In the center we have the paired nasal bone, and on the inferior we have the ascending process of the maxilla, and superior we have the lacrimal bone, and on under surface from the top to bottom we have the bony septum, and then upper end we have the nasal process of the frontal bone, and on the lower end we have the upper lateral cartilage. So at least you have framing in your mind regarding this important component of the bony nasal vault. Then how you assess? Assessment and analysis of bony pyramid for osteotomy is very important. First, look at this picture in the patient. First is the size of the bony pyramid. Look, in the nasofrontal suture area, we have the maximum size of this bony pyramid around the 14 mm. We have the around the 14 mm, and then if you come on the mid, then around the 10, and again there is around the 12 mm. This is the average usual width of the bony pyramid. So this variation in the size is responsible for the shape of bony pyramid. This is responsible for the dorsal aesthetic line, because we have a variation in the size of the bony pyramid. So that is responsible for the hourglass shape and dorsal aesthetic line. And another important thing, length and thickness of the nasal bone. Around that 2.5 centimeter this length of this nasal bone, but if you compare on the top to bottom, in the upper part the thickness is maximum, but if you come down then it gradually thin. So this uppermost part just act as a cantilever for entire nose. So we never enter in this thick part. If you enter in this thick part, then entire nose is fall down. And another important thing regarding the width, we have the 2 types of the width. One is the bony base width. This is the bony base width, and another is the dorsal width. What is the bony base width? The distance between 2 ascending process of maxilla. That is the bony base width. And the distance between the 2 nasal bone, that is the dorsal width. So you have to know your patient is overwide bony base or he have a overwide dorsal width. Because if your patient, suppose your patient have a overwide bony base and your pathway is higher, then what happened? You develop the stair-step deformity. So you have to know regarding the dorsal nasal width, regarding the bony base width, and another important thing, we have the keystone area. So I think everyone you know what is the keystone area. In the keystone area, basically there is a overlapping of the distal part of the nasal bone, and this is the upper lateral cartilage. So this distal part of the nasal bone and this is the upper lateral cartilage. Whenever we do the cadaver demonstration, then you can see very well, we have this overlapping like this. So this overlapping in the center of the nose is around the 10 mm, 10 to 12 mm. But if you go on the laterally, then this overlap is reduced. So the entire upper lateral cartilage gets support from this keystone area. That's why we always say that we always maintain the integrity of the keystone area. So if sometimes the keystone area, the septum is fall down, then it's very difficult to reconstruct by the TTC sutures and the K wires and different sutures. So you have to knowledge all these things for a good osteotomies. Now, osteotomes, because whenever you go for any procedure, you know the dynamics of your instruments also, because instrument knowledge is necessary. So for the lateral osteotomy, usually we use 2 mm or 3 mm osteotome. If you go by the external perforating manner, then you use the 2 mm, and by the go the internal, then you use the 3 mm. And osteotomy is two types. One is the guarded and another is the unguarded.
No.
I think I advocate the guarded osteotomy to my all beginner friends, because when you use the guarded osteotome, then throughout the pathway you can feel where you are working, where you are exactly, because sometimes you reach at the level of the medial canthus, and if you not have the guard, then you enter and you create the problem like the CSF rhinorrhea or something. So guarded osteotome you purchase, and right and left side, both sides the different you purchase. And for the medial osteotome, you use 3 mm straight unguarded osteotome, and for intermediate, the 2 mm is enough. So you have all these osteotomes for proper different type of the osteotomies. Now, we like discuss in the 7 golden step also. We usually have the 4 type of the osteotomy, so never you just bias regarding these all, because whenever you deal with the medial part of this lateral nasal wall, that is the paramedian or median osteotomy, and whenever you deal with this lateral most part of the lateral nasal wall, then is the lateral osteotomy. And if you deal between the topmost and bottom of this lateral nasal wall, that is the intermediate osteotomy. And if you deal with the transverse, this yellow part, that is the transverse or root osteotomy. These are the different type of the osteotomies usually we use in rhinoplasty, but where, which, how can we use, this is the important thing. So first is the lateral osteotomy, because in the all osteotomies, this is the most commonly used osteotomy, lateral osteotomy. So in lateral osteotomy, we have the two important things that the confused to my beginner friends. One is the pattern. What is the low to low? What is the high to high? Someone say high to high is good. Someone say low to low is good. And another is the approach. Someone says, some professor says external is good, internal is good. So we clear these things from your mind. First, pattern. What is the pattern? You know that I think in 1845 when Joseph discovered about the osteotomy, then the pathway of the osteotomy looked at from, this is the piriform aperture, but from he start the osteotomy from lowermost end of the piriform aperture to uppermost. This is the same level. And you know, whenever we use the new technique, then the pro and cons of this technique we realize. So later the Webster realized that whenever we use this technique, then we have the two problem. What is the two problem? Number one, because earlier Joseph used from this part. So whenever you start the osteotomy from this part, then this part is damaged. So on this part medially we have the lateral end of attachment of the upper lateral cartilage. Okay, and on the same side, because we also attach the head of inferior turbinate also. So if you damage this part, then they both are medialized, and ultimately patient develop the airway breathing problem, nasal obstruction. So what he suggests, then rather than if you go, just you go high, little bit high, so you can preserve the Webster triangle. Number one. Number two, when you enter in the uppermost part, then you just, and sometimes if your level is low to low, like look that you in a previous picture, if you go low to low, because during the analysis slide we just see the uppermost part is the thickest part of the nasal bone. So sometimes if your osteotomy enter in thick part, then one part of the this bony pyramid is separate, and he have a like movement like this, that we call the rocker deformity. So he suggests once you reach at the level of the medial canthus, then you change your direction on superior oblique, so we can prevent the rocker deformity also. So he suggests then the standard pattern of the osteotomy is the high, low, high. That means just like a banana shape, just like this is a banana. So the banana shape osteotomy, this is the standard osteotomy. So I think you never bias regarding what is the low one, because we use the two words. One is the high, one is the low. High, that means towards the dorsum. then low, that means towards the ascending process of the maxilla. So high, low, high is the standard pattern of the osteotomy. But you know, in the rhinoplasty, there is no single technique by which you can complete the case. Sometimes, if your patient have an excessive overwide bony mass, then you need the low to low. So it's depend. But this is the standard. Now, approach. We have the two types of the approach. One is the external, that is the percutaneous manner, and another is the internal. So, when you use the internal approach, then like for every osteotomy, like you know regarding the indications regarding the osteotomes and where you engage the osteotome. So first, where you engage the osteotome. So for engage the osteotome, I think for the ENT colleague it's not a big issue because everyone you deal the inferior turbinate. So just you identify the anterior end of the inferior turbinate, and just when you put the Killian's nasal spectrum, you find there is a slit, there is a groove. So on this groove, you just make a 3 mm horizontal incision, not vertical, horizontal incision. Just you engagement of your osteotome, and then you engage your osteotome around 90 degree, not just like parallel to this, and then ask your assistant. Then you use always tap technique, tap, not like, because you don't know, because your mind of your assistant is physically present but mentally absent, not like tap. Ask tap. So you have the synchronizing movement, so you have the less chance of the injury, and throughout your index finger and your thumb, that is the guarding where you are working, because he only hammering, he don't know where you are. So you have a both synchronization, and once you reach at the level of the medial canthus, then or if you are on the right side, then you twist it clockwise, and if you are on the left side, then just you rotate it anti-clockwise. Always ask your assistant, hold the head of the patient. Okay. So like with the same videos, you just engage it. So look at where we are actually. You can see now. So you just engage around the 80 degree, 90 degree. Ask your assistant, then tap, and look that you can see, you can visualize your guarding end of osteotome. This is the guarding of osteotome. So we can break the attachment of the ascending process of maxilla from rest of attachment. So you can see where actually you are fracturing. So if you see there on the outside, that is the nasofacial groove, and inside at the base of lateral nasal wall. And once you reach at the level of the medial canth, because this is the high, low, high. Once you reach at the level of the medial canthus, because this is the left side, so you rotate it on the anti-clockwise manner. And look that now the movement of the lateral nasal wall. Now the lateral nasal wall is the mobilized. Look that you can appreciate the movement of the, this is the fresh cadaver, so you can appreciate. So this is the internal continuous lateral osteotomy. Now for the external approach. For the external approach, first we use the 2 mm osteotome. And I think this is one important advice to my beginner friends, because you need the good instrument. At least osteotomy, rest, the seizures. I think everyone have think in your mind like, I just start the rhinoplasty, once I become a good rhinoplasty surgeon, then I purchase the good instrument. This is the bad thing. Because once you become a good rhinoplasty surgeon, then you can use by Kalelkar and the local company. But in the beginning time, you need the good instrument. So at least you need the good instrument, the 2 mm osteotomes, and where you mark externally, the junction of the nose and cheek you mark in the nasofacial groove, and you make a small straight incision, and then you just engage your osteotome around the 70 degree. Why on the 70 degree? Because if you engage on the 90 degree, if someone hit, then you injured your bony septum. Okay? And by the same incision, 2 or 3 or 4 perforations, and ideally the distance between the 2 perforations, that is the 2 mm. So you have a better green stick fracture. Like in this patient, like in morning we see the video the same. This is the nasofacial groove. So by this you can appreciate where exactly or inside, because outside we make a step incision in this groove, and then just this is a 2 mm osteotome. So just like multiple perforations, so just like a postage stamp manner, and then you need the multiple perforations, and then you do the green stick fracture. So this is the method for the external lateral osteotomies. Because in this video we have the paramedian in a straight manner, so we do the transverse osteotomy more just for mobilize of this lateral nasal wall. And then now you can same on another side, and then you can mobilize the entire bony wall. But you should have the good osteotomes, otherwise it's very difficult. Routinely you have that this 2 mm osteotome. Look at how bony pyramid is mobilized just by the green stick fracture. Like the merits and demerits we already discussed in the morning. Now the medial osteotomies, because there are so many times my beginner friend confusing regarding the median and the paramedian. Ideally look that when you use the paramedian osteotomy, then the important thing, which osteotome you use, the 3 mm osteotome you use. Where you engage your osteotome, you just engage it just at the junction of the nasal bone and the bony septum in 2 mm laterally. That's why we call it because we put it in the parasagittally, that we call the paramedian osteotomy. And now you have the two options. Either you can go the straight manner, and either you can go a 15 to 20 degree position. It's your choice. If you go the 15 to 20 degree position, then you have the advantage, because on other side high low high you make both these points and you have a better movement. So it's your wish. Then like in earlier case I use the transvestibular paramedian osteotomy, because sometimes in a crooked nose the keystone area is damaged. So by this manner you can bypass the this keystone area. So you can preserve the keystone area. So this is the like morning we see this in the straight manner. In a straight manner, when you use in the straight manner, then you have the need the other transverse osteotomy also. And this is the method, that is the direct, just you engage your osteotome in the parasagittal manner. But if you want to the narrowing, it's okay, but in a crooked nose sometimes it's difficult. Now, regarding the intermediate osteotomy, this osteotomy is different. First, the indications. What is the indication of this osteotomy? So, if you have an asymmetrical bony wall, that means the one side nasal bone is the longer than other, one side nasal bone is the convex, other is the concave, then you need this intermediate osteotomy. So, in intermediate osteotomy, where you engage, that is the important thing. So you just mark the top of the dorsum and the nasofacial groove, and the mid of the top and bottom you can engage by the same like the external perforating osteotomy. So this is not routine method. This is only for just demonstration, where you can make just exactly at the mid part of your lateral nasal wall. By this 2 mm osteotome, you can break this lateral nasal wall. So we can say that grossly, this is the junction of the nasal bone with the ascending process of the maxilla. And you can use this 2 mm Medicone instrument, because we need the lot of movement of this lateral nasal wall. So we need this intermediate osteotomy. At least 4 or 5 multiple perforation we need just for mobilize and for getting the more moment. Now the question is that if we need the 3 osteotomy, like in a case like the median or paramedian osteotomy, lateral osteotomy and the intermediate osteotomy, then the both things are important. One is the sequence and another is the which osteotomy you use first. So if you use the 3 osteotomy, then first you use the intermediate osteotomy, because if you use first the lateral osteotomy, then it's very difficult. And if your one side is concave, another side is convex, then concave side first you do the osteotomy, then the convex side. Why? Because mostly mistake done by beginner, they start the osteotomy on the convex side, and it's very difficult. They are frustrating. So if you do the osteotomy first the concave side, then the bone allow to the convex side later when you do the osteotomy. So first you do the concave side. Now the last transverse osteotomy, you know that I think everyone you have the experience sometimes after the 10 days. At the time of the surgery your nose is straight, but after the 10 days when you remove the sting, you are frustrating, still the nose is deviated. This is the one of the important reason, because sometimes the root of the nose is deviated. So if the root of the nose is deviated, and in that case if your osteotomy is not adequate, it's very difficult. So if your patient root of the nose is deviated, then this is the only indications for the transverse osteotomy. And upper limit of the transverse osteotomy, that is the Nasion, and the same manner just like the external perforating manner. Like we already discussed regarding, like if we use the 3 osteotomy, paramedian, lateral and the median, then first you use the intermediate osteotomy, and in concave side first. So like in this video we can discuss, first you mark the entire the bony pyramid, so then superiorly, inferiorly and in the mid part the junction of the nasal bone and the ascending process. So this is for the intermediate osteotomy. We use the Medicone, this 2 mm osteotome by the multiple perforations, and then for getting the more movement, just like the external perforating osteotomy. Then this is the transvestibular paramedian osteotomy. So you just pass from the inside, bypass your keystone area, and then either in the superior oblique fashion or in the straight manner. And then you make incision just anterior head of the inferior turbinate for lateral osteotomy, and then you use on the right side or left side guarded osteotome, and throughout you feel by guarding and where you are working. And look that we are on the right side, so we rotate it clockwise, and your pattern is just like a banana shape, high, low, high, and then you mobilize it in the medially. And if you have some blunt instrument or more bone mobilizer, then you can mobilize your bone. So this is the left side, but on the left side you rotate it on the anti-clockwise. So your nasal bony pyramid is completely free inferiorly, medially, but still we have the attachment superiorly. So when your root of the nose is deviated, then you need the transverse osteotomy more. Otherwise, it's very difficult to stretch. So just do like this, but never go above the intercanthal line. Intercanthal line is an ideal landmark, because sometimes my beginner friend, they have the fear if they do like this, the entire nose is fall down. But it's not happen. It's not happen. But if you need, then definitely you do. Otherwise, you frustrating when you remove the spleen, because when root of the nose is deviated, then you have to go for the transverse osteotomy. Now these are the important things regarding the osteotomy. I think we already discussed. and we have some complications of the osteotomy. So there are some technical complications that at the immediate at time of the surgery, and some functional problem we have the later. But I think mostly by your meticulous examinations, by your meticulous technique, you can avoid the complications. Open roof deformity, I think when a patient have a bump on the nose, and when you remove the bump more than 0.5 centimeter, then you have a space between the center part of the bony pyramid and lateral, that is the open roof deformity. So open roof deformity you can correct by the spreader graft. Another is the rocker deformity. We already discussed the rocker deformity. Then when you enter in the thick uppermost part of the nasal bone, then one part is the free just forward and bonding movement. Then we call the rocker deformity. And badly, if you develop the rocker deformity by the percutaneous osteotomy, we can correct it. So finally, like morning we discussed, there is no standard rhinoplasty. Each procedure unique, and you decide that which surgical technique you use according to your present abnormal anatomical component. Thank you. If you have any questions, then you can ask.